Hello everyone, a very good morning to all of you. I hope I'm clearly visible, audible. Let me confirm. If I'm clearly visible, audible to you people, I will start the lecture ahead. Give me a second for confirming. Just a second. Okay, I hope it is working. So I welcome you all for today's session. A very good morning to all of you. I am Dr. Priyanka here, and today I am here to teach you a topic from systemic pathology. So which system I'm going to teach you today? I'm going to teach you today some important topics from respiratory system. So from respiratory system, I'm going to teach you today all COPDs, chronic obstructive pulmonary diseases. So what are chronic obstructive pulmonary diseases? So before that, I would like to give you an overview of the anatomy and histology of the normal respiratory system. After that, I will start the COPDs. Today, I'm going to teach you four COPDs. Today, I'm going to teach you four COPDs. The first one, I will start with chronic bronchitis. Then I will move on emphysema. Then I will move on asthma. And last, not least, I will teach you bronchiectasis. So these four together are known as chronic obstructive pulmonary diseases. One by one, we will study them in a comparative manner. But before that, an overview of the anatomy, physiology, and histology of normal respiratory system. So you know, in normal respiratory system, humans have two lungs, right lung, left lung. So right lung have three lobes. Right lung have three lobes. You can see this is right lung, upper lobe, middle lobe, lower lobe. And in the left lung, only two lobes are present, upper and lower. There is no middle lobe. So you can see here right में three are present, but in left only two lobes are present, upper and lower. There is no middle lobe. So the middle lobe of the left lung is represented by a small segment known as lingula. So here question comes on the lingula. You can mark lingula here. The middle lobe of the left lung is represented by a small section here that is known as lingula. So lingula is the middle lobe of the left lung. It is an important MCQ from the anatomy. Please learn that. Please learn that. Now, coming on the respiratory tract. We know respiratory tract is divided into two parts, upper respiratory tract and lower respiratory tract. For understanding you what is upper, what is lower, I would like to draw a diagram. So you know in humans, respiratory tract starts from nose. So person is breathing from the nose. The nose will open in nasopharynx. Nasopharynx will open in hypopharynx. Hypopharynx will open in larynx. So this is pharynx. This is larynx. Larynx will open in trachea. This is trachea. Trachea will divide into two bronchi. The main bronchi, the two right and left main bronchi. Bronchi will divide into bronchioles. The first bronchiole is primary bronchiole, then secondary bronchiole. Secondary bronchiole will give rise to tertiary bronchiole. Tertiary bronchiole will give rise to terminal bronchiole, the last bronchiole. Primary will give rise to secondary, secondary will give rise to tertiary, tertiary will give rise to terminal bronchiole. From terminal bronchiole, respiratory bronchiole arises. From respiratory bronchiole, multiple alveolar ducts arises. And from alveolar ducts, the balloon-like structures known as alveolar sac or alveoli arises. So you can see from nose it is starting. So what are the parts? Once enumerate: nose, pharynx, larynx. Nose, pharynx, larynx. These three structures are known as upper respiratory tract. Up to larynx it is upper respiratory tract, and starting from trachea, bronchi, all the bronchioles, whether it is primary, secondary, tertiary, terminal or respiratory, then alveolar duct and alveolar sac. These all together are known as lower respiratory tract. So today I am going to teach you diseases of lower respiratory tract in pathology. Upper respiratory tract diseases will be dealt in ENT, right? Okay. So here you can see the complete division. One more important point, the last three things, the last three divisions here. What are the last three divisions? Respiratory bronchiole, alveolar duct and alveolar sac or alveoli. These three things together are known as acinus. Acinus. Acinus is the structural and functional unit of the lung. Like glomerulus is the structural and functional unit of the kidney. In the same way, acinus is the structural and functional unit of the lung. Have you got it? So this is the complete respiratory tree. Please have a look and learn the sequence in this diagram. So what is lower respiratory tract? You tell me. In lower respiratory tract, it starts from trachea. Trachea divides into two bronchi, the principal bronchi, right and left bronchi. Bronchi will give rise to bronchioles. First primary, then secondary, then tertiary. Tertiary bronchiole give rise to last terminal bronchiole. Terminal bronchiole में से निकलेगा respiratory bronchiole, then alveolar duct, then alveolar sac. These last three things together are known as acinus. So you can see the complete starting from the nose here. So this is a good diagram showing the same thing. This is the good diagram showing you the bronchi, primary, secondary, tertiary. So likewise, it is getting divided. So this is the best diagram you can appreciate. So you can appreciate the right and the left bronchus, then primary, secondary, tertiary bronchiole, terminal bronchiole, respiratory bronchiole, alveolar duct, and alveolar sac. These three things together, this is one acinus. One acinus. So you can see the same diagram. I'm going to teach you most of the pathologies in this diagram. You can appreciate this is acinus. This is acinus. One acinus. Acinus. It contains what? It contains respiratory bronchiole, one respiratory bronchiole, all the alveolar ducts arising from it, and all the alveolar sacs arising from it. So one respiratory bronchiole with all its appendages, it is known as one acinus. So we have already studied it. Larynx, trachea, and bronchi have cartilage. They have C-shaped rings, that is cartilage. So same diagram. So what is acinus? We have already studied it. What is acinus? So distal to the terminal bronchiole, whatever is present, distal to terminal bronchiole, three things are present. Respiratory bronchiole, alveolar duct, alveolar sac. These together known as acinus. So this is a diagram of one acinus as I have already marked for you. So it is distal to terminal bronchiole, not including terminal bronchiole. Please mind it. Please mind it. So this is the complete tree in front of you. So this is trachea, which will divide in primary bronchi. It will divide in the main primary right and left bronchi. Then divide in bronchiole, primary, secondary, tertiary bronchiole. And it will give rise to terminal bronchiole. It will give rise to respiratory bronchiole. Then alveolar duct. Alveolar duct is not written here. You can write it down. And then alveoli or alveolar sac. And these three things distally are known as acinus. So please learn the sequence. I'm going to mark my 4 COPDs today in this sequence only. So some COPDs are the diseases of trachea. Some COPDs are the diseases of acinus. So they have different levels. They have different levels. So if you understood this, just a second, let me come on the histology. What is the histology of the lung? So entire respiratory tree is lined by columnar epithelia. It is a special type of columnar epithelia which is pseudo-stratified. What do you mean by pseudo-stratification? It looks multi-layer, but it is not actual multi-layer. Because the location of the nucleus is in different layers, it is looking the cells are multi-layered. Just suppose, let me draw few cells here. So these are the cells of columnar epithelia. So nucleus is here, 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 here. So it is looking, it is multi-layer, but it is single layer. So pseudo-stratified columnar epithelia. So it is known as pseudo-stratified ciliated columnar epithelia. It is also having cilia. One more special property, that it is having cilia on the surface, right? So cilia is a defense mechanism, right? And what are the lining of this alveolar duct, alveolar sac? Alveolar sac, ये पूरी की lining तो ये है. The complete respiratory tree is lined by pseudo-stratified ciliated columnar epithelia. ये तो हो गया. But what about the lining of alveolar sac? The last thing. Alveolar sacs are lined by pneumocytes, type 1 and type 2. There are two types of pneumocytes, type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes are 95%, type 2 are only 5%. Type 2 secretes surfactant. They synthesize surfactant. You know what is surfactant? It is a substance which lower the surface tension. So they help in, expansion of these alveolus. Otherwise, if surfactant is absent, the alveolus will collapse. That is the point. Have you got it? Okay. Let me move further. Now, in the entire respiratory tract, you have 4 layers. The innermost layer is known as mucosa. Let me mark mucosa here. This is mucosa, pseudo-stratified ciliated columnar epithelia. The second layer is the submucosa. Let me mark submucosa here. This is entire submucosa. In the submucosa, you have glands. Please understand, you have glands. The third layer is muscularis propria, which contains cartilage. You can see this is muscularis propria and it contains cartilage also. And outermost layer is the adventitia or serosa. So there are 4 layers. You can see the best diagram here also. You can see the 4 layers here. So this is mucosa. Please appreciate mucosa, pseudo-stratified ciliated columnar epithelia. This is submucosa containing glands. The glands are present in submucosa. If you can understand this, you will understand chronic bronchitis. Chronic bronchitis means there is problem in the submucosa. The glands will undergo hypertrophy and hyperplasia, right? The third layer is muscularis propria, having cartilage inside it. And outermost layer is adventitia or serosa. So these are the 4 layers you should understand. Yeah. So I'm not launching the MCQs based on the anatomy and physiology. It's very easy. Yeah. The last thing is the collateral pathway. Collateral pathway. Can you understand this diagram? What it is? It is a respiratory bronchiole. This is a respiratory bronchiole, you can see, And from one respiratory bronchiole, these are the alveolar ducts arising. This is one alveolar duct. This is another alveolar duct. See, so these are the alveolar ducts and these are the alveolar sacs. That is balloon-like structures. The alveolar sacs are there. The balloons, the last structure. These are the alveolar sacs. Now, are there any connections between them? Yes, there are connections between them. So, what are the connections between them? The two alveolar sac or alveoli are combined with each other with a small hole or a pore, which is known as pore of Cohen. It is an important MCQ. Pore of Cohen is connection between two alveolus. That's why it is known as interalveolar collateral. Interalveolar collateral, connecting two interalveolar, right, from inside. That is one thing, right? The second connection is between two bronchiole. Two bronchiole. It is known as channel of Martin. It is again important MCQ. It is interbronchiolar, the two bronchioles. And the third connection, one alveolus, one bronchiole. So it is known as bronchioalveolar. It is known as channel of Lambert. Channel of Lambert. Have you got it? Have you got it? So you can see pore of Cohen, channel of Martin, and channel of Lambert. So you can see their other names. It is interalveolar, interbronchiolar, and bronchioalveolar. It is connecting two alveoli. It is connecting two bronchiole and it is connecting one bronchiole, one alveolar. So you have to learn it. KML. KML is the mnemonic. In this diagram, you can learn like KML. Pores of Cohen, channel of Martin, channel of Lambert. So what does they mean? They mean that K is interalveolar, M is interbronchiolar, and Lambert is bronchioalveolar. Between two alveoli, between two bronchi, between one bronchi and alveolar. Please learn these basics so that you will have a better understanding of the diseases. The last thing before starting the four types of COPDs is that alveolar septum. What is alveolar septum? So, you know, whenever air is going inside, ultimately I am taking the air from the nose. Listen. So all the air from my nose, where it is going? It is going in the pharynx, in the larynx, in the trachea, into the bronchi, primary, secondary, tertiary bronchiole, terminal bronchiole, respiratory bronchiole, and alveolar duct, alveolar sac. So ultimately, all the air which I am inhaling, it is reaching here. It is reaching in these balloons, in this balloon. Whatever air I am taking, we all are taking from nose, it is reaching in the alveolar sacs. Now, what will happen to the air from here? After reaching here in the alveolar sacs or the balloons, the entire respiratory tract or balloons are lined by capillaries. Can you see? These are the pulmonary capillaries. They all are lined by pulmonary capillaries everywhere. Now gaseous exchange take place. Let me draw a diagram for you. Okay. Okay. You can see this is a balloon. By balloon, I mean alveolar sac. Right. This is the alveolar sac. So inside the alveolar sac, the air is present. Right. And it is surrounded by a blood capillary, that is pulmonary capillary. So this is pulmonary capillary. So in this is now gaseous exchange kya honge? The oxygen from here wants to come here for purifying the blood and carbon dioxide from here wants to go there so that blood purification take place. But the gases have to cross few membranes. What are the membranes the gases have to cross? The gases have to cross three layers. What are the three layers? What are the three layers? So you know this is capillary. Capillary is lined by basement membrane. This is basement membrane at the center. You can see this is the basement membrane at the center. Basement membrane at the center, and capillary lining is endothelium. And this is endothelial lining of the capillary. Endothelial lining of the capillary, basement membrane, and on other side, inside the alveolar sac, the lining of the alveolar sac is pneumocytes or epithelial cells. So these are the layers the gases have to cross. So whenever gases are crossing from here to here or here to here, three things have to be crossed: epithelium, endothelium, और उन दोनों के बीच में basement membrane. Have you got it? So see this beautiful diagram. You can understand this from the diagram. So you can see this is the capillary. Inside the capillary, this is the endothelial lining in the capillary, and this is alveolar sac having epithelial lining. So epithelium and endothelium के बीच में है, on one side endothelium, on one side epithelium, alveolar sac में capillary endothelium, और बीच में है basement membrane. You can see this is the best diagram I can show you. The yellow color is the basement membrane. Can you appreciate yellow color there? This yellow color is the basement membrane. On one side of the basement membrane, this is endothelium. This is endothelium on the blue color cell, and on the other side, the green color cell is the epithelium. That is pneumocyte, type 1 and type 2 pneumocyte. So this is the best diagram you can understand. So after that, okay, so this is the final diagram of normal lung. In normal lung, we have these spaces which are known as alveolar spaces. All these spaces are alveolar spaces. Please appreciate. And in between to them, these are the blood capillaries. These are the blood capillaries. So this is the master diagram in which I am going to show you all diseases. Let me start COPDs now. So you already have an overview of the anatomy of the lung, physiology of the lung, and histology of the lung. Now let me start the diseases. The diseases I am going to teach you today are COPDs, chronic obstructive pulmonary disease. What are COPDs? As the name indicate, these are obstructive diseases. Now what is obstruction? Obstruction can be chronic, can be partial or complete, and can be at any level starting from trachea to the alveolus. Starting from trachea se leke till alveolus, either at the trachea or bronchi or primary bronchiole, secondary bronchiole, tertiary bronchiole, terminal bronchiole, respiratory bronchiole, and finally alveolar duct or alveolar sac. From trachea to the smallest airway, it can be at any level. The reason is different. So there are actually 5 types of COPDs from which I will teach you the first 4. So chronic bronchitis is the first one. Emphysema is the second one. Bronchial asthma is the third one. Bronchitis is the fourth one. And bronchiolitis is the fifth one. Now don't get confused. This is bronchitis. This is bronchitis. And this is bronchiolitis. You should pronounce them clearly. These are absolutely different diseases. So I will teach you the first 4, the most important one by one in a comparative manner. So start with the first one, chronic bronchitis. We are starting with the first one, chronic bronchitis. Make this comparative table with me. If you wish, you can make it. So chronic bronchitis, emphysema, asthma, and bronchitis, which I am going to teach you today. So what is their location? At what level they are causing the obstruction? From in respiratory tree, the entire complete respiratory tree, starting from trachea till alveolus, where they are causing the obstruction. Second, what is the age of the diagnosis? The third, what is the reason, etiology, pathogenesis, gross, microscopy, and clinical features. So please make a comparative table if you wish. It will be easy for you for solving MCQs if you make this table with me. Let me start with the first one, chronic bronchitis. What is the definition of chronic bronchitis? Give me a minute. Let me see if I can see your video. Yes or no. Give me a minute. Okay. Okay, I hope I can see. So what is chronic bronchitis? Now, imagine a person is coming to your clinic that doctor, I'm having cough. Doctor, I'm having a problem. What is the problem? I'm having cough. So the first question you will ask this person, cough with sputum or without sputum? You know sputum is there in the cough. So cough is dry or with sputum or without. So it is cough with sputum. It is cough with sputum. So you will ask from how many days you are having this cough. So the person is having cough from last 3 months and it is not responding to any antibiotics. At least from more than last 3 months, minimum 3 months or more than 3 months. And you will ask, is it happening every year? So every year from the last 2 years or more than the 2 years, every year, in a year 12 months are there. From the 12 months, 3 of the months he is having this cough. So the person is having a disease known as chronic bronchitis. So the definition of chronic bronchitis is clinical. So what is the clinical definition? Persistent cough with expectoration. Expectoration का meaning होता है sputum. So persistent cough with sputum on most of the days for last 3 months. Last 3 months से patient को cough है or it is for 2 or more consecutive years. हर साल. So in 2020 also more than 3 years he was having cough. In 2021 also more than 3 months. More than 3 months of this year he was having cough. He was having cough and cough was with expectoration. So 2 साल से ज़्यादा हो गए हैं ऐसा करते करते and every year more than 3 months he is having cough constantly, right? So that is the disease is known as chronic bronchitis. Now what is the pathogenesis behind it? It usually occurs in males, the middle aged males. Adults में होता है, males में होता है, children में नहीं होता, females में less common है, right? What is the pathogenesis? As I have told you, it is a disease of trachea and bronchi. पहली बात, it is a disease of trachea and bronchi, not of this. So here write down chronic bronchitis. In the chronic bronchitis, in the trachea and in the bronchi, we have 4 layers. We have 4 layers. These are the 4 layers. You can see these are the 4 layers. So this is mucosa. You can appreciate. This is submucosa containing glands. This is muscularis propria containing cartilage. And this is adventitia. You can see the 4 layers very well, right? Imagine if a person is smoking. So where the smoke will go? Smoking. So smoke will go in the trachea and in the bronchi. The smoke will go in the trachea and the bronchi. It will irritate the layers of the respiratory tree. So here is the smoke in the lumen. Can you see? This is the lumen. So lumen have the smoke. So it will put a stress on the wall of the bronchial tree. So stress. So this smoke is putting stress here. Stress here. Smoke is putting stress. To respond that stress, there are some adaptation. So these glands in the submucosa, they will do two adaptation. They will do hypertrophy and hyperplasia in response to smoke. Hyperplasia and hypertrophy in response to smoke. So the glands undergo hypertrophy. Hypertrophy means increase in size, and hyperplasia means increase in number. So they increase in number as well as increase in size. So the layer, this submucosa layer will got thickened. Rest of the layers are not thickened. Only submucosa size increases, thickness increases because of hypertrophy and hyperplasia of the glands. Now, normally what does these glands do? These glands form the secretion from the secretion inside them, and the secretion will come into the lumen. So lumen have a secretion. The lumen is wet, small amount of secretions which is secreted from the glands, the secretions. But now the glands are more in number, so they will form more secretion. So more and more and more secretion will come in the lumen. So the secretion will obstruct the lumen of the trachea and the bronchi. So the person will feel obstruction. Person have difficulty in breathing. Just suppose I am the person, in my trachea and in my bronchi, there are 4 layers. So because of smoking, the submucosa, the second layer got irritated, and the glands inside submucosa will undergo hypertrophy, hyperplasia. They will put more secretions in the lumen. The lumen is partially obstructed and the person is having difficulty in breathing. The main chief complaint symptom here is dyspnea. So patient will complain of dyspnea. So to relieve dyspnea, the patient will do the cough with sputum. So all the secretions will come in sputum. So patient will cough so that sputum is cleared off. It will come out and the respiratory tree, trachea and bronchi open up again. Give me a thumbs up if you got it. So what is the etiology? Etiology is smoking. Etiology, it is mainly due to smoking. Give me a thumbs up. तो स्मोकिंग की वजह से ये पूरा हो रहा है. स्मोकिंग की वजह से क्या हो रहा है? देयर इज ओवर सिक्रीशन ऑफ द म्यूकस ड्यू टू इंक्रीज इन नंबर एंड इंक्रीज इन साइज ऑफ द सबम्यूकोसल ग्लैंड. सो इट इज अ प्रॉब्लम ऑफ द सबम्यूकोसा की ग्लैंड्स की साइज और नंबर बढ़ गया. तो दैट इज अ प्रॉब्लम. इट इज ड्यू टू स्मोकिंग की वजह से हुआ. तो ट्रेकिया ब्रोंकाई में, सबम्यूकोसा में, ग्लैंड्स में हाइपरट्रॉफी और हाइपरप्लेशिया होने की वजह से more secretions. So it is causing the obstruction. It is leading to cough with sputum. So make this flowchart for you. Give me a thumbs up if you got it. So grossly, if you take the lung out of such person, this is the diagram of the lung. Can you see? These are bronchi. These are bronchi. Can you notice the sputum here? Can you notice the secretions? More secretions. The secretions are obstructing the lumen. Please appreciate. So that is the thing. What is microscopy? If you cut this lung and make a slide, what you will see? So please see this diagram. Very important. Many MCQs are asked from this diagram. You can compare two diagrams. This is normal. This is chronic bronchitis. Please compare the two diagrams. This is a normal diagram and this is chronic bronchitis diagram. Please have a comparison between the two. What you can see. See the 4 layers there also, here also. Okay. First we will see the mucosa. So see the mucosa normally. This is the normal mucosa. This is the normal mucosa. In the normal mucosa, you can appreciate this cell and this cell is goblet cell. So only 2 goblet cells are there in normal mucosa. But see the mucosa here in chronic bronchitis. So how many goblet cells we have? Mucosa mein we have many goblet cells. You can see 1, 2, 3, 4. So in the mucosa, goblet cell hyperplasia. That is the change in mucosa. Main change occurs in submucosa. Let me show you submucosa here normally. See 1, 2, 3, 4, 5, 6. 6 glands are there and see their size. और यहाँ पे देखो in chronic bronchitis, so you can count the number of glands. Definitely the number is more as well as size is more. So glands undergo hypertrophy and hyperplasia and they are doing more secretion. So more glands, increase in size also, number also. Muscular propria is same in both of them. Adventitia is same in both of them. So main change occurs in submucosa. You can see the thickness of the submucosa in both of them. Thickness of the submucosa in both of them. Here I would like to tell you a term known as Reid index. Very, very, very important. An index known as Reid index. क्या होता है Reid index? Reid index, does anyone know what is Reid index? See the full thickness of the submucosa और उसमें thickness of the gland. So thickness of the gland in the numerator and total thickness in the denominator. This index, the numerator and denominator is known as Reid index. See यहाँ पे thickness of the gland और total thickness. यहाँ पे see thickness of the gland and total thickness. So numerator is increasing यहाँ पे. So numerator is increasing, so Reid index increases in chronic bronchitis. You can see here also. You can see this is the thickness of the gland. Okay, I will show you. This is the thickness of the glands, and this is the total thickness, total. So A upon B, you can say A upon B is the Reid index. Have you got it? This is Reid index. So Reid index increases. So please write down what are the changes here. What are the changes? Number one, Reid index is increased, not decreased. Normal Reid index is 4 upon 10, 0.4. It is 4 by 10. So total thickness is 10. 10 में से glands is 4 and it is more than 0.4 now. Reid index is the ratio of two things, numerator, denominator. The numerator have thickness of the submucosal gland. The denominator have total thickness. Total thickness. So these are the things. After that, goblet cells are increased. We have seen. So these are the changes in chronic bronchitis. Again, you can see this is Reid index. Thickness of the gland in the numerator, total thickness in the denominator. So it is BC upon AD. That is BC upon AD, whatever you say. So you should understand what is it. What are the clinical features? The persistent patient have persistent cough and dyspnea. Cough with sputum and dyspnea. Because of the dyspnea, patient can't breathe. If the patient can't breathe, patient will go in cyanosis. Because of cyanosis, patient will look bluish in color. That is known as blue bloater. So cough, dyspnea, blue bloater. You have to learn these three findings. So I'm done with chronic bronchitis. Would you like to do some polls based on it? Many MCQs come from this topic, chronic bronchitis. So, okay, this is the first question in front of you. All those who are listening, please write your answer in the chat box if you know what is the correct answer. Just now I taught you the Reid index. You tell me what is true about it. Reid index is useful in which disease? Is it useful in glomerulonephritis? Is it useful in chronic bronchitis? Is it useful in cirrhosis? Or is it useful in MI? In which disease it is useful? Of course, it is useful in chronic bronchitis. So the correct answer here is B. It is useful in chronic bronchitis, right? What is Reid index? Is it increased in chronic bronchitis or decreased in chronic bronchitis? Increased in asthma or decreased in asthma? Of course, it is useful in chronic bronchitis, not in asthma. So rule out these two options. In chronic bronchitis also it is increased, not decreased. So correct answer here is A. So that is how you have to approach your questions. So many questions from chronic bronchitis based on the Reid index. Now coming on the second COPD, emphysema. I'm coming on the second COPD, that is emphysema. What is emphysema? Emphysema. So you know in this tree, emphysema is a disease of acinus. Emphysema is a disease of acinus. Chronic bronchitis was a disease of trachea and bronchi, but emphysema is a disease of acinus. Now what is the problem here in the acinus? So see, these are the multiple acinus. 1, 2, 3, multiple acinus are there, right? So what will happen? This is the wall of the acinus. The wall of the acinus will become weak. The wall of the acinus, will become weak. So they burst out and multiple acinus fuses with each other and form big spaces. These are known as bullae. So acinus fuse with each other and they will form bullae because of weakening of the wall. Now the question arises, why the wall become weak? Why? Again, the reason is smoking. So smoking leads to both chronic bronchitis also, emphysema also. It is due to smoking. Now, why due to smoking? Now, in the wall, this is the wall. See, this is the wall of the acinus wall. In the wall, there are two types of enzymes are there. One is known as protease. One is known as antiprotease. The another name of protease is elastase. Or also known as antiprotease is known as anti-elastase. One more name is given to them is trypsin, trypsin, and alpha-1 antitrypsin. Alpha-1 antitrypsin, right? So one and the same thing. So what does these enzymes do? They cause destruction of the wall of the alveolus because they degrade protein. They degrade elastin, right? They degrade the protein, protease, elastase, trypsin, but they all inhibit the destruction. They inhibit the destruction of the wall. They promote destruction, they inhibit destruction of the wall. And normally their concentration is equal and opposite. So they cancel out each other. In my lung, your lung, in all of us, they cancel out. There is a balance between them. But there are some persons who smoke. If there is a person who is doing smoking, because of the smoke, these will increase and these will decrease. So imbalance occur in their concentration. The one which are destroying got increased and the one which are inhibiting the destruction are decreased. So destruction occurs in the wall. So because of the destruction, multiple walls fuses with each other and bullae are formed. That is the etiology. Have you got it? That is known as emphysema. So what is the definition of emphysema? Emphysema is permanent dilatation of the air spaces. Air spaces. Which air spaces? Which are distal to terminal bronchiole. That is acinus. Distal to the terminal bronchiole, three things are there. Respiratory bronchiole, alveolar duct, alveolar sac. Right? That is terminal bronchiole. And destruction of their walls. So destruction ho jayega walls ka. You can see here the theory is Proteus anti-Proteus theory. Proteus anti-Proteus hypothesis. Proteus is known as elastase. Anti-Proteus is known as anti-elastase or antitrypsin. So normally they balance each other, but imbalance occurred because of smoking. Because of smoking, there is increase in Proteus and decrease in anti-Proteus or anti-elastase. You can see this is smoking. You can see this is smoking. This is a BD or cigarette. So it is decreasing anti-Proteus and increasing Proteus. So it is causing damage to the wall and multiple acinas fuses with each other and form big spaces which are known as bullae, right? So that is the bullae. Now, how many types of emphysema are there? Emphysema is basically of 5 types. Centriacinar, panacinar, Paraseptal, irregular and mixed. What do you mean by that? What do you mean by that? Have you understood what is emphysema? Have you understood what is emphysema? So the last three structures of the respiratory tree, that is, this is respiratory bronchiole. From one respiratory bronchiole, many alveolar ducts arises. So just suppose these are the alveolar ducts arising from one respiratory bronchiole. From one respiratory duct, multiple alveolar sacs are arising. Just suppose these are the alveolar sacs as arising from them. These are the alveolar sacs arising from them, right? You can see alveolar sac, alveolar sac, alveolar sac. These all are alveolar sacs arising from the alveolar duct. This is normal. This is normal. Now, destruction occurs in their wall and they are fusing with each other. That is known as emphysema. That is known as emphysema. So, destruction, there are 3 types of destruction. The one which is occurring, if the destruction, just a second, you can see here, if the destruction is occurring in the wall of the respiratory bronchiole, so this will get dilated. So only respiratory bronchiole, multiple, they will fuse with each other and because of destruction of the wall, it will dilate it. So it is a central structure, now. It is a central for all. So it is known as Centriacinar. This type of emphysema is known as Centriacinar. Centriacinar emphysema because the central structure is dilated, not the others. In one type of emphysema, only alveolar sacs, multiple alveolar sacs fuses with each other and they form big spaces, that is bullae, right? So the distal structure, so it is known as paraseptal or distal emphysema or paraseptal emphysema, paraseptal emphysema. Have you got it? And the third type in which all of them are dilated, all of them. So it is known as panacinar. Pen matlab all. When? So there are 3 types: centriacinar, distal or paraseptal, one and the same thing, and panacinar. Have you got it? Have you got it? What are the 3 types? So the main 3 types are centriacinar, only the central structure is dilated, that is respiratory bronchiole. Panacinar, all are dilated. All means all 3. What all 3? Respiratory bronchiole giving rise to alveolar duct giving rise to alveolar sac. And paraseptal, only the distal is dilated, that is alveolar sac. So what is dilating? Only respiratory bronchiole or only alveolar sac or all of them? So it depends the 3 type. Irregular is irregular. कुछ भी dilate हो सकता है, थोड़ा यहाँ, थोड़ा यहाँ, थोड़ा यहाँ. So that is haphazard and mixed pattern can be there. So these 2 patterns are not really very important, but the first 3 are important. So you can see the best diagram I can find out. You yourself see this diagram and tell me what it is. Which structure is dilated? Only the central structure is dilated, that is respiratory bronchiole. So it is centriacinar. Have you got it? What about this? Only the distal structure is dilated. So it is paraseptal. Right? Here all 3 are dilated. All 3. Respiratory bronchiole, alveolar duct and alveolar sac. So that is known as panacinar. And this is irregular. Haphazardly they are dilated. So that is the thing. That is the thing. Have you got it? Same diagram. Now, you should understand the difference between the pan and centri. I have already told you, pan mein everything is dilated. And in centri, only the central structure is dilated. That is respiratory bronchiole. We have understood it, right? So this is the respiratory bronchiole, alveolar duct or alveolar sac. These 3 things are there. इनमें से क्या-क्या dilate हो रहा है? So once they dilate, so big spaces are formed. Can you appreciate these big spaces? These are bullae. These are bullae, right? So I advise you to make 3 columns or to make 4 columns to study the 4 types. So first I will teach you centri. Then I will teach you panacinar. Then I will teach you distal or paraseptal. and last is irregular. Last is irregular. You should write the differences. First, write the definition. In Centri, only respiratory bronchiole is dilated. Panacinar, all the three structures are dilated. Distal में alveolar sac is dilated. Irregular is irregular. You should write one predisposing factor for all of them. So you have to tell one predisposing factor for all of them. For Centriacinar, the most important predisposing factor here will be smoking. I guess it is smoking. So let's see one by one. One predisposing factor and upper lung or lower lung. Which lobe of the lung is involved? That is also important. So let's start with the first one. Please fill this table with me. Centriacinar. Centriacinar emphysema. It is the most common. सबसे पहला. अच्छा. I told you 4 types, na? What are the 4 types? Centriacinar, panacinar, distal and irregular. Which is the most common? 2 questions I am going to ask. So irregular is most common, but it is undiagnosed. It is undiagnosed because it do not produce any symptoms. But most common to be diagnosed is Centriacinar. So please read your question very carefully. Both are already asked in previous year question. So if it is only said what is the most common, answer is irregular. Most common is irregular, but it is not diagnosed because maybe it is present in me, in you, but it is not producing any symptoms. So how it will be diagnosed? The one which is most commonly diagnosed is Centriacinar because it produces symptoms. Have you got it? Have you got it? Emphysema, asthma, Rihan, I will come on that. So asthma is my next disease to be taught you. So in Centriacinar, I am teaching you Centriacinar. Centriacinar, it is the most common type. Pehli baat, right? Here the central structure, only respiratory bronchiole is dilated, not the others, right? Okay. It occurs in heavy smoker. Smoking is the risk, and it occurs in upper lobe, right? So this one, the central structure is dilated. You can appreciate, okay? Panacinar, all 3 structures are dilated. Respiratory bronchiole, alveolar duct and alveolar sac. All 3 structures are dilated. It occurs in lower lobe. Here the risk factor is alpha 1 antitrypsin deficiency. वहां पे risk factor smoking थी, यहाँ पे अल्फा 1 यहाँ पे स्मोकिंग था, यहाँ पे अल्फा 1 एंटीट्रिप्सिन डिफिशियंसी है. ये अपर लोब में है, ये लोअर लोब में है. प्लीज अप्रिशिएट, राइट? That is the thing. You can see this is normal. Appreciate the 3 structures in the normal, everyone. Appreciate this is respiratory bronchiole. These are alveolar ducts and these balloons are alveolar sac. All of them are normal. So if only respiratory bronchiole is dilated, it is Centriacinar. If all of them are dilated, it is Panacinar. So please appreciate. The third one is the distal. It occurs only in alveolar sac. It again occurs in upper half. And here the most important risk factor is spontaneous pneumothorax. It is a disease of the lung, right? So sabka ek ek, and last is irregular. Irregular is due to scarring. Risk factor is scarring. It is the most common type, but not diagnosed. So let me form a table between them. As I have told you, most common is irregular, but clinically not significant because undiagnosed. So autopsy पे most common मिलता है ये. Right, but overall most common which is diagnosed clinically is Centriacinar. ये दो most important questions हैं यहाँ पर. So this table I am going to draw for you. The last thing. So the 4 types I am going to write: Centriacinar, panacinar, distal and irregular. Please write this table with me. Write the definition of all of them. You already know the definition. Here respiratory bronchiole. Here all structures. Here distal में क्या होगा? Here respiratory bronchiole is dilated. Here all structures are dilated. Distal में alveolar sac is dilated and here irregular is there. So what is the risk factor? Here the risk factor is smoking. Risk factor पे बहुत clues मिलते हैं. A smoker, emphysema. So answer is Centriacinar. Alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency may emphysema. So answer is Panacinar. Right? Spontaneous pneumothorax. Spontaneous pneumothorax में emphysema. Answer is distal. Or scarring due to any reason. उसमें emphysema हो रहा है due to TB, due to lung cancer, due to anything. So it is irregular. So one risk factor you have to learn. You can't escape. It occurs in upper lobe, it occurs in lower lobe, it occurs in upper lobe again. Do not have any propensity for any lobe. So it can occur anywhere. Give me a thumbs up. So please learn this table. Many MCQs come from it and learn the diagrams also. Right? Here the lung become voluminous and you can appreciate the bulle. Right? Bulle and blabs. So bulle and blabs are there. Can you appreciate these bulles? Okay. Can you appreciate? So multiple alveolar sac fuses with each other and forms these bulle. So these are the bulle. Multiple alveolar sac. They fuses with each other and form big bulle. These are the bulle and blabs. You have to appreciate these bulle on the surface of the lung. So learn this term bulle. Microscopically, this is the diagram. What you can notice? You can notice, ma'am, these are the big alveolar sacs. Multiple alveolar sacs fuses with each other and we can see the broken walls. Can you see? The wall is broken. So this is a broken wall. So that is purse of the broken septa. Their septa are broken. This is one. They fuses with each other like this, they fuses with each other. So in their junction, you can appreciate the spur of the broken wall, the spurs. So that is the thing. So dilated and distended alveolar sacs, spurs of the broken wall, and thinned out stretched wall. It is the you say it is a spotter. It comes in the form of the image based question in your exam, right? Clinical feature, again the patient will present with dyspnea here. Cough bhi hoga lekin cough kam hoga. So we have studied two diseases today. What are the two diseases? Chronic bronchitis and emphysema. You have to understand the differences between them. Chronic bronchitis is a disease of trachea and bronchi, and emphysema is a disease of acinus, that is respiratory bronchiole, alveolar duct and alveolar sac. लेवल ये अलग अलग है. यहाँ पे मेन कंप्लेन आपका होगा कफ, और यहाँ पे मेन कंप्लेन आपका होगा डिस्निया. These are the pink, these are the blue blotters because of cyanosis. These are pink puffers because of absence of cyanosis, right? So please understand the differences between them. My third disease is asthma. So four diseases I have to teach. I have already taught you two types of COPD. Chronic bronchitis and emphysema is done by me. The three more COPDs are remaining: asthma, bronchiectasis, and bronchiolitis. So total 5 COPDs are there in your syllabus. So please understand, level of all of them is different, etiology of all of them is different, types is different, gross is different, microscopy is different. So I always teach these COPDs in a comparative manner. So etiology, pathogenesis, gross, microscopy, and clinical feature. This you have to write in comparison. Till now, please read this and compare them. Compare them. So we have finished two. The remaining three we will go do in the next lecture. Currently, just after 5 minutes, I'm having next lecture on YouTube only. I'm going to teach you hepatitis. All the hepatitis serology. Hepatitis serology, very, very important. So the complete hepatitis A, B, C, D, E, all hepatitis, acute, chronic, and all types of histological diagram of the and the fulminant, acute, chronic, and fulminant. So all hepatitis I am going to teach you where. So the next lecture after 5 minutes, that is at 9:15, I am having at YouTube only, but on another YouTube channel, that is Let's Crack NEET PG. Let's Crack NEET PG YouTube channel. I am having this lecture. So please connect with me there after 5 minutes. So thank you very much for attending this lecture, and I will cover the remaining COPDs tomorrow in this lecture only, morning 8 o'clock, right? So thank you very much for being with me. Don't forget to write your feedback in the comment box if you learned this lecture. If you have missed it, please watch the recording from the beginning. In the beginning, I have given you an overview of the normal anatomy, physiology, and histology of the respiratory tract of the lung. After that, I have started the diseases. The first disease I taught you, chronic bronchitis. The second disease I taught you is emphysema. So next class will be after 5 minutes on another YouTube channel of Unacademy. Let's Crack NEET PG. If you want detailed lectures and recordings, please install Unacademy Learners app from the Play Store. Go to NEET PG category and look for my name. My name is Dr. Priyanka Sachdev. You will find my profile link there. In my profile link, you have to follow my profile link. Once you follow my profile link, you will get more than 200 lectures or 300 lectures are available free. You can watch any lecture by clicking on the link. Patho, Pharma, Micro, Medicine, PSM, many, the complete syllabus is available. The only thing you require a code to unlock it. The code is Sachdev10. SACHDEV, Sachdev10 is the code to unlock it. Thank you very much. And for the newcomers who don't know, on Unacademy, we have two type of paid subscription. The one is Plus, one is Iconic. In Plus, you get access to both live and recorded lectures of Unacademy from India's top educators, along with question bank and live test and quizzes. But on Iconic, along with Unacademy, all the features of the I have enumerated for Plus, you will get additional advantage of prep ladder. So better to go with Iconic. So these are the features. When you take the subscription, you will be eligible for all these batches, all these features. So please get the benefit of these offers which are currently available on the platform and take your subscription. What you can do, go to Unacademy Learners app, look for various plans available in the Plus, look for various plans available in the Iconic. Check for their prices. So you can notice longer the plan, cheaper it is. So if you're a first prof, second prof student, please go with a longer plan. It is cost effective to you. Otherwise, if you are an intern, final year, go with a shorter plan. 3 months, 6 months is also available. Whatever plan you take according to your wish, according to your need, apply code Sachdev10 before payment. Sachdev10 is the code to be applied before payment. SACHDEV before payment. Apply the code Sachdev10 to get straightforward 10% discount. Thank you very much. See you all after 10 minutes for studying hepatitis.